Hello fellow residents, so today I'll be talking about my journey in the first year of residency. It was a year or more ago I entered my dream hospital as a first year resident after passing through all those hurdles of entrance exams and counseling. First week into the residency, I was clueless, so many new things. How do I use the slit lamp? What do I have to see? What findings are my seniors talking about? Being a curious child, I kept irritating my mentor and he tried the level best to teach me. Few months went by. I started using the slit lamp. But every time I saw an interesting finding in the patient, I had to rush him to the slit lamp photography room, which was on another floor of the hospital. It was inconvenient for the patient and time consuming as well. I then started using the smartphone adapter, which could be attached to the slit lamp. It was a good tool but needed a lot of adjustments, and it was tiring to keep removing it and putting it again and again. And then CAMS, Vision Center, peripheral posting started, where all I had was a torch sometimes. I wasn't sure of my findings a lot of times. Also, emergency nights would be frustrating. All I could do is explain my seniors about my findings on call so that they could help me with the further management of the patient. I started looking out for easier and better options. The other day, I was in my college library and I came across an article on the Indian Journal of Ophthalmology. The author used an intraocular lens to make a simple attachment to the smartphone to take anterior segment photographs. I was surprised how simple and efficient it was at the same time. I went back to my hostel room and made the same tool as instructed by the author in the article. So let me tell you how I made my ASPI. First, take a chart paper and a scale and a pen to draw a rectangle measuring 10 cm 1.5 cm. You cut it out with a scalpel and then take a scalpel to just mark the center part of the rectangle and fold it across. Then, after folding the chart paper, you use a double-sided tape, stick it on one side of the chart paper. You stick it properly and then we take a puncher to punch a hole in between the rectangle to make a small opening where we can attach the intraocular lens. You then remove the other side of the double-sided tape. You take the 15 diopters intraocular lens and attach it on the circular opening. And then you stick the other side of the chart paper and sandwich the intraocular lens on both the sides. I then take my smartphone and attach the ASPI onto the smartphone camera with a micropore tape. Ready, there you go. You switch on the flash for better pictures. Oh, that's me taking ASPI picture on a patient in an outreach camp. So now I would like to share you my ASPI picture collection. I hope you don't get jealous. My photography gallery for lid related pathologies: canaliculitis, blepharitis due to Demodex pathogen, pityriasis palpebral, meibomian gland capping, meibomian gland carcinoma, heart-tick infestation on the upper lid, few conjunctival pathologies, conjunctival cyst, capillary hemangioma, nasal pterygium, bite spot, ocular surface squamous neoplasia, ophthalmomiasis, subconjunctival hemorrhage. Few corneal findings were metallic corneal foreign body, epithelial reticular edema, corneal sutures, OSSN of cornea, foreign body, dendritic ulcer, and full thickness corneal tear. Few pupillary and iris findings were correctopia, hypochromic iris, ice syndrome, iris coloboma, neovascularization of iris, and irises. Few uveal pathologies: post-op uveitis, seclusopupillae, posterior synechiae, granulomatous scabies. few cataract images, posterior polar cataract, lamellar cataract, electric shock induced cataract, mature cataract, pyramidal cataract, and pseudo exfoliation. Intraocular related findings: intraocular pitting, iris claw lens, anterior capsular phimosis, phakic IOL with silicone oil bubbles, optic capture, and yak cap opening. I was using my smartphone aided ASPI for camps, emergency duties, case discussions, to counsel patients regarding their treatment and how the pathology looks like, for publications, and for expert opinions whenever required and in doubt. Many of my batchmates started using them after my great experience, and we now have a WhatsApp group called ASPI Club, wherein we discuss and share interesting clinical findings or pictures on the group. I would suggest ASPI for every resident. It's a simple, low-cost, innovative tool which can be useful for every resident from first to final year, and it requires no specialized training. It can be used for case discussions, treatment, publications, photo documentation in a rural or emergency setup devoid of slit lamp.